We're all human. And it's important to know that doctors are people too. Doctors have emotions, they have passions in life and hobbies, and they enjoy participating as active members in the communities where they practice medicine. Doctors have families, friends, and relationships, while the latest in healthcare and the most current treatments for ailments will be topics on this Doctors Are People Too radio TV show. The focus will be in learning more about the interesting aspects in a physician's life and what they do away from the doctor's office or operating room table.
You'll be syndicated throughout the world.
Hi, welcome South Florida and beyond, and on the iHeartRadio app. Welcome to Doctors Are People Too. I'm really excited tonight because we have an orthopedic surgeon and sports medicine specialist in the studio tonight. I don't think we've had one of those yet. We did have a few other medical specialties, but I want to welcome Dr. Jonathan Hirsch. Dr. Hirsch, how are you tonight?
Great, David. Thanks for having me.
And thanks for coming on Doctors Are People Too. I really appreciate it. Very, very media savvy doctor, and someone I follow closely. I know you've done a lot of work. You're kind of the Dr. James Andrews of our time. So anyone who watches ESPN remembers Dr. Andrews and how he comments and kind of explains a little bit on the ailments as an expert orthopedic surgeon. So I'm really happy to have you on. Let's get right into it, though. I know you're doing a lot with biotechnology, and that's kind of a new thing, a new term kind of that I've seen recently. And I want to talk to you about how you're using a patient's own cells to repair the knee with clinical research you're doing. So let's start out there. What kind of biotechnology research are you doing to using the patient's own cells to repair the knee?
Thanks, David. Well, basically, for years, we've used cellular technology for cartilage transplantation. So backing up, when people have knee pain, arthritis is a common source, and arthritis means loss of cartilage. So there are people who have loss of cartilage in only small focal areas, and we can take their cartilage and with tissue engineering, grow that cartilage into something larger and transplant it back into the knee. There's a company called Asculap that I'm doing part of a national randomized study where we're enrolling patients with these ailments, taking their cells. Their own cells are then impregnated into a collagen implant that 3 weeks after we take their cartilage, a second surgery is performed, and we basically sew in a little disc of collagen impregnated with their own cells. So it is research, but it's been available in Europe for over 10 years. Over 10,000 patients have done great. But since the FDA requires this to be tested here before putting it on the market, we have to do a phase 3 trial. It's very exciting. It's different than some of the other cartilage transplants that we're doing in that the disc that's impregnated with their cells can be directly sewn into the knee. And we're seeing just amazing results. And these are patients who, some of them have had multiple surgeries beforehand, some of them are fresh, and really helping young patients, get through the pain of these early arthritis-type problems.
So this is amazing stuff. I mean, when you're just listening to it. So the patient's own cartilage is grown in a laboratory. So it's their own cartilage. It's not from a cadaver or a donor. And then you're able to put it back into the knee in just 3 weeks later. Is that correct?
Correct, yes.
Okay.
Some of the options that we have are cadaver transplants for certain size lesions, and some people have elected to do that. But this is cellular technology, again, using their own tissue is really exciting.
And this actual surgery, is this something that can be done besides like what we've seen in the last few years, microfracture, I believe, and you can help me a little bit with this, is how the holes are drilled into the cartilage or bone, and then that acts as a way for the cartilage and bone to heal. But it seems to be like a little better option in a way, a little quicker, more minimally invasive.
Well, it's interesting you mentioned microfracture because that's actually the control arm of the study. So the randomization in this process is that patients come in and they're randomized to either microfracture or this newer technology called NovaCart 3D. The microfracture has been around for a long time. It's basically using the patient's own stem cells. So you puncture holes into the bone where you get bleeding, and that blood can turn into cartilage-like cells. And it works. And about 75 to 80% of patients do get pain relief, but what we're finding over the long term, 10, 15 years, it's not lasting. So we're looking for something that's going to be much longer lasting. But in this specific studies, as in many other studies, it is compared to the microfracture procedure, which is a one-step procedure.
I see. And if anyone is interested in this, how does a clinical trial work? Do they contact the physician directly, or the local hospital, or how does that work for a patient maybe considering this option?
Yeah, for anyone local, they actually just have to call my office. We do have a research coordinator, but we can facilitate that introduction through my office number.
Okay, let's give that out. Dr. Hirsch, tell everyone where you're located, your office number, and website.
Here in Boca Raton, my office is actually on Southwest 18th and Powerline Road, so it's 6853 Southwest 18th Street here in Boca Raton. Our office number is 561-417-3339.
Great. And then now, let's stay on the clinical research topic for just a second, because I know last year there was some big news about a rotator cuff clinical research trial that you were involved in, or maybe you still are involved in. Maybe you can share with the listeners a little bit about the Rotation Medical for rotator cuff.
Yeah, actually, the clinical trial has been done already. We're actually implanting a rotator cuff patch. It's actually made from cow Achilles tendon. So they have found that the Achilles tendon has such abundant collagen and a robust structure that they can make it into a patch that we sew into the shoulder, staple into the shoulder arthroscopically after we've done a rotator cuff repair. And even more exciting, we're using it for patients which are very common, a partial rotator cuff tear. It actually induces healing of these really frustrating partial tears, which we encounter a lot. So it's been really satisfying, very minimally invasive, and people from all over the counties have come because of that to really ask for help in regards to their rotator cuff repair, which, that tendon sometimes is not easy to get to heal.
And what are some of the more common shoulder injuries you see? You mentioned rotator cuff, and I actually, when I played football, I had that rotator cuff injury, and that's kind of a nagging thing, because I think what happened is the cartilage got into, and you can explain this a little bit, the ball, and it was kind of rubbing against each other, and I think that's where the pain and discomfort came from. But what is the most common shoulder injury you see, and also what types of shoulder injuries do you treat?
Well, the rotator cuff certainly is probably the most common source of pain over the age of 40. Whether we like it or not, that tendon starts to degenerate in our 40s and 50s, and even without injury, you can get micro tears and inflammation and bursitis and so on. And then into our 50s, 60s, 70s, you can get tears, certainly with an injury and a fall, or with just the wear and tear of playing tennis or doing certain things and work for a long, long time. Arthritis sort of is a common source of pain that we see, and I do also shoulder replacements in addition to shoulder arthroscopy, and those are our patients in our 60s, 70s, and beyond. The younger population, we're seeing more instability. The younger athletes in their teens and 20s, dislocated shoulders, multiple dislocating shoulders that we repair arthroscopically, and some of the more chronic dislocators, we do more extensive procedures. But most of our surgery now is done minimally invasive, arthroscopically or through small incisions when we can, and definitely minimizes the pain of surgery.
We're here with Dr. Jonathan Hirsch, orthopedic surgeon and sports medicine specialist, expert in arthroscopic surgery, right here in Boca Raton. So we got one of our orthopedic surgeons right here in our listening area at 6853 Southwest 18th Street, Suite M11. And that's in Boca Raton. And Dr. Hirsch, you were telling me that it's on a very big corner there. Is it Powerline and
18th, Southwest 18th and Powerline?
Okay.
You can't miss it with all the construction going on in our plaza, so you can't miss it.
And Dr. Hirsch is at 561-417-3339, and he told us his website is hirschmd.com. And if you want to call in, we're here with Dr. Hirsch, 1-888-565-1470. Dr. Hirsch, do you also treat elbow injuries and biceps as well? And if so, what kind of ailments would a patient or someone, family member who may be suffering from those kind of ailments ask their primary care if they can be referred to, orthopedic surgeon for those kind of elbow and bicep injuries?
Sure, I do a lot of elbow surgery, both arthroscopic and open. You mentioned the biceps. So a distal biceps rupture almost always is an indication for surgery. That we do through very small incisions these days. So a biceps rupture is a very common thing I see. It also in tennis elbow. Tennis elbow or chronic tendonitis of the elbow, extremely common, not just in tennis players who we see a lot of, but in just housewives, laborers, different athletes. Really doesn't matter. Tennis elbow sort of hits every age and every athletic endeavor and every job. And it can be a real long haul for some of these patients, but we have a lot of minimally invasive techniques with injections such as platelet-rich plasma in the office that we do, which is sort of a stem cell-like procedure, as well as a 10X procedure where we do a percutaneous ultrasound-guided tenotomy, and all this stuff is on our website. But, really, elbow is a large portion of my practice.
Now, he just mentioned his website. Dr. Hirsch's website is hirschmd.com. You can get all of his areas of interest. There's board certifications, education and training, what hospital he's on staff at. I believe, Dr. Hirsch, you're on staff at West Boca Medical Center?
Correct.
Okay, great. Now, what are the age range of the patients you treat? Because I think that's kind of a mystery to us, some people who aren't doctors. I mean, do you treat before 18? Do you treat mostly after? I mean, what age range?
My practice is basically adolescents and above, so between 10 and 12, around 10, 11, 12, depending on the diagnosis. I'll treat until 99 to 100. We have some patients almost approaching 100. Luckily, I have an excellent partner in pediatric orthopedics. Takes care of a lot of complex pediatric orthopedic stuff, Dr. Jeffers, so we work together. But I'll see, little fractures, sports injuries in kids, adolescents, and adults.
Now, that's Dr. Kenneth Jeffers right there in Boca Raton, pediatric orthopedic surgeon. Now, let's stay on the topic of tennis because you have a unique medical directorship here locally. You work a lot with the Delray Beach Open, which is our huge ATP 250 men's tennis tournament. That's the pro men's tennis tournament in Delray Beach. That's kind of a neat thing, and I know you see a lot of different ailments. Kind of tell the listeners a little bit about what you do as medical director of the Delray Beach Open and how you can help pro players stay on the court.
Yeah, every year in February we have a 10-day tournament. As you said, the Delray Beach Open, which is both a senior tour and the regular ATP tour. And so my responsibility is medical coverage for the event. Whenever there's a match on court, we have medical staff there, either myself or colleagues that help. And throughout the year, a lot of these athletes live in South Florida or train in South Florida. So we see them really all year round, not just during that tournament. But it's exciting. You get to meet the top players in the world and work with them and learn a little bit about their training and some of the challenges that they have medically. They are traveling around the world constantly, and we have a team of physicians throughout the world that we communicate about their health. We communicate electronically a lot and by phone to help sort of treat their ongoing ailments, because most of what they suffer from are ongoing overuse problems. Occasionally you have an acute event at the event, but most of it's things that have been nagging them, and we have to figure out, is it some time to take off, or is it something they can work through?
So their electronic health records are forwarded to you, and you could be on site for anything from a bee sting to a shoulder dislocation, a sprained ankle, or any of those things.
Anything, medical or surgical or orthopedic related, we have to be available for it. Exactly.
We're going to take a quick break, but on the other side, we'll talk to Dr. Hirsch about some of the hip injuries he treats, and then also knee injuries, which is a huge part of his practice and something he can explain to the listeners.
My dad is a cardiologist, and so I have two brothers, and we're all equally painful to my mom. And so to get us out of the hospital, we would go on rounds with him on Saturdays and Sundays in the hospital back in Oklahoma City. And we used to, race wheelchairs down the hallways from the time I was about 6 years old. When I was a freshman in high school, I got to watch my first heart transplant. But I think what really kind of made me want to be a doctor was around the holidays. The house always filled up with tons of gifts from thankful patients, and to impact people's lives like that in a positive manner was something that was very exciting to me. I'm very patient-oriented. I care about the patients both professionally and personally, and not only about their result, but also that I'm passionate about new technologies. I'm passionate about research, and I'm passionate about offering them the best technology available with the lowest risk and with the best outcome. What you want in a physician is someone who is personable, works as a team, embraces new technology, is clearly accomplished, but I think most importantly is somebody who you get confidence in. And the way I would have confidence is if I had a condition, I would read as much about it as I could before I showed up, probably off the internet, and then ask very directed questions. I do a lot of exercise. Running is what I use to kind of calm my brain down and kind of sort my thoughts out. So I enjoy, I just will put my shoes on and go for a run, and then I do mix in a little bit of yoga, something probably not many people know about me. I keep that on the down low, but so I do some yoga, and I go to the gym like most people.
You are listening to Doctors Are People Too with David DiPino, who shows us the human side of medical doctors in the community. If you have a question for our guest, call into the show at 888-565-1470. Now, let's get back to the fun side of doctors and show that they are people too.
And welcome back on Doctors Are People Too. We have Dr. Jonathan Hirsch in the studio. He's an orthopedic surgeon and sports medicine specialist, expert in arthroscopic surgery. We already talked about the elbow and shoulder, and we're going to talk about a few other areas of the body that he treats orthopedically. He's at 6853 Southwest 18th Street, Suite M11 there in Boca Raton. 561-417-3339 is how you can reach Dr. Hirsch's office. And one of the easiest doctor websites I've come across, HirschMD.com. That's HERSCHMD.com. Dr. Hirsch, let's, and I'm going to probably butcher this, but let's talk a little bit about subchondroplasty and how it helps in treating knee injuries. It's a new term that I recently came across, but obviously we have a physician here, so if you can tell us a little bit about what it is.
Great. Subchondroplasty is patients, arthritic patients we've discovered over the years on their MRIs, which we don't always get, but you get an MRI in an arthritic patient. We've noticed that in the bone marrow there's extensive edema, swelling, and sometimes a little crack in the bone from the weakness, from the arthritis. And we have found in these patients, some of these patients, if you can get rid of the bone marrow swelling, a lot of their pain goes away even though they still have the arthritis. So it's a minimally invasive procedure. With a small needle, you inject a bone graft cement. It's made out of the same products as bone. It's a liquid that fills the cavity of where the swelling is and the little fracture. That hardens, and then it becomes new bone. And as the swelling of the bone goes away, as this bone graft incorporates, we find that some of their really bad pain goes away. We're taking their pain from a 10 maybe to a 2. And these are patients who either too young for a knee replacement or just don't want one. I've also had patients who are athletes who had stress fractures around the knee, no arthritis, and I've used this procedure to treat their stress fracture by injecting the cement into the stress fracture. It's done with x-ray, and we also put a camera in the knee as well to make sure we don't get anything in the knee. And it takes maybe 20 minutes. It's been really gratifying if you choose the right patient. It's been a great operation. Now people are doing it in the talus of the ankle. Some people have done it in the hip and shoulder, and sort of really expanding the locations that we're doing this in.
So the actual time that you are doing surgery is only 20 minutes?
Yeah, it doesn't take very long. It takes about, once you inject the cement, we wait about 8 minutes for it to harden. Mm-hmm. And if there's no other procedure we're doing at the time we're done, sometimes we're also cleaning out the knee. People have debris or meniscus tears, so we combine the procedures. Maybe it takes another 15, 20 minutes, but it's outpatient. And some of these are patients where you look at the x-ray and absolutely a knee replacement is their only choice. But then you get the MRI, you find these other findings, and you don't burn any bridges. It's a small procedure. And if we can make them more comfortable while they're living their life, playing tennis, golf, whatever, that's what they're looking for. Not everyone's looking for a joint replacement. They're looking for alternatives, and that's what I try to provide.
And what is the recovery time? What's the time it takes to get back on the court for subchondroplasty for treating knee injuries?
It takes a while. It probably takes a couple of months. We've seen 3 months or so for the pain to completely resolve, sometimes quicker. But you're really looking at a sort of bone substitution, bone growing through the area with this bone graft as a catalyst. And so it takes some time.
That's great to hear. I mean, 20 minutes, I mean, it sounds like it's pretty minimally invasive, and then you're able to clean out some cartilage in there as well, or other, things that may be ailing the patient's knee. And outpatient, I mean, who wouldn't want to hear outpatient? I mean, that is...
Yeah, the patients we've chosen have really all been real satisfied. And again, like I said, stress fractures, arthritis with fractures, and it's been really an excellent experience so far. We've been doing it for about a year now, and throughout the country, it's been around for about 2 years, 3 years. And the results have been really, really well received.
Well, let's talk a little bit about the knee, because I think as listeners and the common person will think, orthopedic surgery, the first thing I think is knee. So what are some of the most common knee injuries you're seeing nowadays, and what kind of treatments do you provide for the knee with orthopedic surgery and sports medicine?
Well, right now we sort of consider this ACL season. It's football season. Where a lot of ACL tears, anterior cruciate ligament tears occur. And so ACL reconstructions right now is probably one of the more common procedures I'm doing in the fall. Certainly, any kind of ligament procedure in the knee, I do. Most of the time, arthroscopic replacement. But overall, meniscus tears seems to be the most prevalent throughout the world of what we're doing arthroscopically in the knee. In the younger population, certainly knee arthroscopy for meniscus tears is extremely common. We do have techniques to repair the meniscus, and there's some exciting stuff coming now that we can replace meniscus tissue that's coming on the market very soon. The older patients, we're learning that not everyone with a meniscus tear needs an operation, and we're trying some alternative medicine, PRP, as I mentioned before, or just therapy and time. And so but the meniscus tear seems to be one of the more common injury and surgery that we're performing as well.
Let's get into hip arthroscopy. There seems to be a lot of leaps and bounds made in this field of orthopedic surgery in the last few years. We're hearing, that patients aren't spending as much time in the hospital. It seems like the orthopedic surgeon community has really made some leaps in discovering ways to treat hip fractures and other ailments of the hip. So tell the listeners a little bit about what you do for hip injuries.
For hip arthroscopy, is really a minimally invasive way getting into a real challenging space. Years ago, you had to completely dislocate the hip open to get to some of the diagnoses such as labrum tears and FAI, or femoral acetabular impingement. So we're finding that if we can get to patients with FAI and labral tears early, we are probably going to prevent these patients from getting arthritis in the future, because we do believe that FAI and labral tears are a precursor to arthritis. So with the arthroscope now and minimally invasive techniques, we can get into the hip, repair the labrum, remove bony abnormalities that they may have, whether they're congenital or they've developed them over time with sports, and getting people back to playing sports rather quickly. So a hip arthroscopy is night and day from what we used to do when we opened and dislocated the hip. And so we can really do a lot with the hip, with the scope now in the hip. And it's an exciting operation.
So we're here with Dr. Jonathan Hirsch, orthopedic surgeon and sports medicine specialist here in Boca Raton. Website is hirschmd.com. That's HERSCHMD.com. And phone number is 561-417-3339. Dr. Hirsch, I'm going to bring this full circle now. We talked about Dr. James Andrews, or I did at the beginning. I watched ESPN growing up. I still do today, and they seem to always go to Dr. James Andrews to talk a little bit about the recent injury. And I know you've been doing a lot of work with media lately on them calling you for the latest injuries in the NFL or Major League Baseball, National Hockey League, Olympics you talked about recently. So one thing I want to talk about, though, is How can groin injuries, hamstring, quadricep injuries, those kind of muscle injuries affect the knee and hip? And if they're not taken care of with sports medicine, how can these ailments cause real big problems down the road?
Well, you mentioned quadriceps and hamstring strains. Those large muscles cross the hip and the knee, which makes it much more challenging because you can't rest those muscles, and they're constantly working opposite each other, like a hamstring. It crosses the hip and the pelvis, and it crosses the knee, and it's constantly moving in opposite directions. And athletes such as Gronkowski right now on the Patriots, who's out with a hamstring, who have to sprint, they just cannot, and they're out for quite some time in a muscle tear. They rarely require surgery unless they're avulsed off the bone, but they can be amenable to stem cells and PRP, and we can do some stuff now to accelerate healing, but they require rest for the most part, relative rest with some rehab, but they can cause athletes to be out for quite some time, lose careers. Some athletes have just gone in and out with, let's say, hamstring or quad strains that just quite never heal, and then they go back in and tear them all over again. So muscle, we don't talk a lot about muscle injuries in orthopedics because it's not sexy because we don't operate on them, but we see a lot of it. And it's rarely surgical, but it's working with our therapy colleagues and our massage therapists and acupuncturists to do all sorts of stuff to make patients better. Because really, muscle tears and ligament sprains are so many injuries that don't get a lot of press, but they're real and they can be devastating.
And that's more in the sports medicine realm of the treatment you provide?
Correct. And most of what an orthopedic sports medicine specialist is going to do is non-surgical, and certainly my practice is surgical, but a lot of non-surgical. And it's really getting people to the specialists that can put their hands on them and knowing who those are in our community that can make their recovery faster.
And we're here with Dr. Hirsch. He's in our community right here in Boca Raton, 6853 Southwest 18th Street, Suite M11. And that's Boca Raton, and 561-417-3339. And you made a great point there. When we think of orthopedic surgeon, we're always kind of thinking of, surgery. Obviously, it's the first thing in your medical title there, but it's important to know that Dr. Hirsch is also available for sports medicine, and sometimes he can prescribe, a treatment plan that doesn't require surgery. So that's important to know. This question I always love getting to if we have time. And what do you do outside of surgery? I mean, you're putting in long hours as an orthopedic surgeon, very established in the Boca Raton community. But what are some of your passions and your life outside of being an orthopedic surgeon?
Well, personally, I get up every day, 5 o'clock, go to the gym, try to work out before I go to either the hospital or to the office. Play tennis when I can. Play different sports with my children. My son play basketball. We go fishing. My daughters, one plays soccer. The other, a lot of times just playing dad. And just spending free time with my kids and friends and family. But athletics is still important in my life. So tennis, golf, and really the weightlifting keeps me going.
And then also, do you have a passion in music at all that you can tell us about?
Yeah, I've recently gone back to the studio, learning, practicing again, playing the drums, trying to form a band with a couple of friends who are involved in the medical field. Again, another outlet for something to do is play. Maybe we'll be playing some bars around Boca one of these days. But yeah, I've been playing the drums since junior high school.
Nice. And do you have a favorite drummer?
I think most drummers say Neil Peart from Rush is probably their favorite. But I have a lot of jazz training, so there are a lot of jazz drummers that I've followed over the years. Gene Krupa, Buddy Rich, guys who are no longer with us, who still, if you look back at what they did with such a small little drum kit, is absolutely still amazing.
That's great, Dr. Hirsch. Dr. Hirsch, thank you so much for coming on the program. It's hirschmd.com, and thanks again for being on Doctors Are People Too.
David, thanks for having me.
Thank you.
Hi, my name is Dr. Rahul Agarwal. I'm an interventional cardiologist in Jupiter, Florida. I did my medical school at the University of Florida and my internship and residency at the same program. I did my chief residency also at Shands, and then did my cardiology and interventional cardiology at Wake Forest University in Winston-Salem, North Carolina. I specialize in general cardiology interventional cardiology, and nuclear cardiology. Even though I'm an interventional cardiologist, the majority of my practice involves general cardiology. General cardiology is a pretty broad spectrum in that it involves rhythm problems such as atrial fibrillation, heart disease such as coronary artery disease, congenital heart disease, high blood pressure, and cholesterol problems. I do procedures such as cardioversions, which involve trying to convert the patient back to a normal rhythm if they have an arrhythmia. Also deal with plumbing problems such as the coronary arteries, which if they're blocked, I can do angioplasty and stents, which involves balloons that open up the arteries. And these stents act as scaffolds that keep these arteries open. I really do believe in preventive medicine, and one of the areas that I really focus on is diet. One can really get caught up on the pills aspect and the exercise. And diet we talk about a lot, but unless one really has some guidance as to where to go with diet, it can be quite difficult. So I do give my patients homework in terms of books or movies that they can rent or obtain so that they can get educated. Our cardiology office is located in the Abacoa area of Jupiter, Florida, conveniently located between two of the local hospitals. We provide echocardiography, stress testing, ultra monitoring, and general cardiology office visits. We really pride our practice in its staff, who are very courteous and professional. We believe that under our care, you'll feel the same way too.
You are listening to Doctors Are People Too with David DiPino, who shows us the human side of medical doctors in the community. If you have a question for our guest, call into the show at 888-565-1470. Now, let's get back to the fun side of doctors and show that they are people too.
And we're back on Doctors Are People Too. Hello, South Florida and beyond, and on the iHeartRadio app. We're really lucky tonight because we have one of the preeminent cardiologists in the area, in the Delray Beach area, Dr. Eric Lieberman, with us tonight. Dr. Lieberman, how are you doing?
I'm doing great. Thanks for having me, David. I appreciate it.
Thank you for coming over on such quick notice. I know you have some big information for actually local doctors and nurses in the community. So obviously this is Doctors Are People Too, so we're interviewing doctors every week. And I want to give the listeners a chance to learn a little bit more about what's going on with their physicians in the community, and in the form of symposiums where physicians, experts from around the country get together and they talk about the medical specialty with some of the nationally renowned experts and internationally renowned experts in that medical specialty. So, Dr. Lieberman, I'm going to ask you to tell us a little bit about the Innovations in Cardiac Care Symposium coming up October 7th, 8th, right here in Boca Raton. We're on the air right here in Boca Raton, and this is right in our backyard. So can you tell us a little bit more about it?
Sure. This is actually our third year doing this annual CME program. It's an opportunity for us to get our physicians, nurses, and other healthcare professionals together in one room on one day to learn about the newest advances in cardiovascular care. We try and focus on new developments, cutting-edge technology, new treatments available to our patients, because we want our cardiovascular and internal medicine specialists, as well as our nurses and other healthcare professionals, to be up to date on the services we're providing through the Tenet Heart and Vascular Network. And this is a perfect opportunity to do so. We do it by bringing in experts from around the country. These are really the leading experts, including this year we're fortunate to have Dr. Cox with us. Dr. James Cox actually invented the first surgical approach to the management of atrial fibrillation, which is a very common arrhythmia of the heart that we often deal with medication, but here's an alternate approach. So this is really a great opportunity for physicians locally to attend a meeting which is achieved national recognition. Our numbers are growing every year, and it truly provides a look into the future of cardiovascular care.
That was perfect, Dr. Lehman. I know we hear a lot about CMEs, and we have doctors listening and nurses listening and the general population driving around listening. So what is a CME? And as a doctor, or do you have to get a certain number of them every year?
Yeah, so CME is continuing medical education. It is required for physicians. There are state licensing requirements to go with it. Although I would say those state licensing requirements are the bare minimum of what you need to do to maintain cutting-edge healthcare delivery for your patients. The reality is that medical knowledge turns over about every 2 to 3 years. If you simply practice how you were taught in medical school, your knowledge base becomes deficient within a few year period. And so the state, as is recognized across states throughout the country, require physicians to maintain continuing medical education. It's also encouraged by various specialty boards. And we certainly want our physicians to be up to date so that we can provide our patients with the technology that's available and the treatments that are available today. And that's the concept behind continuing medical education. One of the things that we find unique about our conference and that we truly enjoy is that we do it combined with our nurses and other healthcare professionals, because it is a team approach to medicine. As physicians, we can only be as good as those who provide the care along with us. So we want everyone sitting there hearing the knowledge and hearing what's going on. So as a team, we can move forward together.
And Dr. Lieberman, you made kind of smirking over here because here we have doctors who have, got their board certifications, went to medical school, fellowship in some cases, and then you have to go back to school and get education every couple of years, not back to school. But what I'm saying is you have to stay up on that. It seems like you guys never stop studying. Does it ever end?
It doesn't end. It's a nightly ritual. You go home, you read your journal articles. Obviously, there are now internet options available to you as well. Many of us take the time to take a few days or a week or so a year to actually go away to a meeting. I think there's something to be said for actually immersing yourself in the educational process rather than just doing it at night or at weekends. You're reading journal articles constantly. You're trying to keep up with the latest changes in medication and treatments that are available. I think it's probably what draws a lot of us into medicine is the continuous part of the educational process, the fact that we never get stale from an intellectual standpoint, and allows us to continue to provide care and keep ourselves interested in what we do.
And I'll be honest with you, up until 5 years ago, I didn't know what atrial fibrillation was. I remember seeing the commercials and kind of laughing in a way, like, oh, my atrial fibrillation, this and that is causing a heart rhythm. But then when you really find out what it is, and that, the flutter in the chest, and how it can lead to even stroke and other things. And this is huge that you guys, all this leeway you've made in the past few years in research. I'm talking you guys cardiologists, cardiothoracic surgeons. And so I think that is really neat. And I know you said the first thing about the Innovations in Cardiac Care Symposium was there's going to be a big focus on atrial fibrillation. So let's just tell the listeners again. So it's October 7th and 8th, and it's at the Boca Raton Resort. Am I correct?
It's actually at the Fort Lauderdale Ritz-Carlton this year.
Oh, I'm sorry.
Our first year we were at Boca Raton. We actually outgrew our size there, and so we moved to a larger meeting room that better accommodated our needs, and also a little further south so we could basically make it easier for some of our colleagues in Miami-Dade and Broward County to attend. It is October 7th and 8th. The primary part of the educational program is on October 8th. We are doing some interesting things this year. We have a networking event on the evening of the 7th for our physicians and nurses to interact. We're actually bringing in some of our national healthcare leaders from around the country for a small get-together that Friday afternoon to discuss how we can work together as a national group of thought leaders on doing research and improving the quality of care. And then we embark on the CME program bright and early Saturday morning.
Okay, and I was at the first one in Boca Raton, so that's why I kind of messed that up. That was at the Boca Raton Resort, but this one is in Fort Lauderdale, October 7th and 8th. You know where you can get the information is at THVN and then the word symposium.com. So that's THVN SYMPOSIUM.com is where you can get all the information. Let's go right back a little bit on the CMEs. So nurses, doctors obviously work with a ton of nurses in the hospital setting. So nurses actually can attend and they'll get their CMEs at this event. They have to, obviously, I believe, pre-register. Is that the way it works?
Right. So registration is open now. We actually have a couple hundred people registered for the meeting already, which we are ahead of our pace for last year. Nurses are required to maintain continuing education as well. It's part of their licensing process. Again, we like to have the nurses and physicians together at this meeting. One of the things we're doing differently this year is we do have a separate lunchtime breakout for the nurses, and basically we're responding to the requests of our nurses. In the first 2 years, they asked if they could have a dedicated session to issues particular to nursing, and so we've added that this year. We did not want to detract from their participation in the rest of the symposium, so it was added in addition to the remainder of the courses that we're giving.
And again, that's thvnsymposium.com. If you're a doctor or nurse, or you have a family member in the medical field as a doctor or nurse, or even if you want to let your doctor know about it. And this is available to not only, I know you're affiliated with Tenet Florida Heart and Vascular Network, but this is outside of Tenet. Any doctor or nurse from other organizations can attend?
Absolutely. We encourage attendance from all physicians. We have physicians who are affiliated with Tenet facilities, physicians who are not affiliated with Tenet facilities. We've had physicians come from around the country. I think this meeting is beginning to gather a little more traction nationally as well. We often have guests joining us from the Caribbean. So any healthcare professional is welcome to join our meeting as long as they just want to learn something. That's really what it's about, learning the latest cardiovascular innovations.
And you can't beat Fort Lauderdale Beach this time of the year. It seems like the sun's going down a little earlier. It's getting a little bit cooler. I mean, we can kind of say that. So that's an awesome place to be on Fort Lauderdale Beach.
Absolutely. And the meeting room, actually, as you come out of the meeting room and when we have some time for socializing in between, the view is beautiful.
Great, Dr. Lieberman. I couldn't ask for anything more there. That's thvnsymposium.com. We're going to take a break in a minute, but I just want to ask you also, you mentioned atrial fibrillation is going to be a big part of this, this symposium. What kind of treatments do you provide as a cardiologist for atrial fibrillation?
So as a general cardiologist, we're also often involved in the initial diagnosis and management of patients with atrial fibrillation. And atrial fibrillation, as you appropriately pointed out earlier, has a number of issues that need to be addressed. And you brought up the most important of which is stroke. So one of the first things we want to do is alleviate or minimize the risk of stroke. So it'll often be a conversation with a patient about starting on some type of blood thinner, and there are many options available these days to reduce the risk of stroke. In addition, atrial fibrillation is often associated with a rapid heartbeat, so medications are necessary to try and slow the heartbeat. And then we'll embark on a more long-term strategy of trying to normalize the heart rhythm. Now, again, in terms of emerging technologies, there are newer surgical treatments for atrial fibrillation. There are ablative options where we put catheters in the heart. That's not done by somebody like me, a general cardiologist. It's done by an electrophysiologist who's basically an electrician of the heart, where they can do a procedure to try and restore normal rhythm. And the other thing that's become available relatively recently is the ability to put a device in the heart called the Watchman device to actually close the area of the heart where most of the blood clots form, and therefore minimize the risk of stroke without the ongoing need for anticoagulation. We're actually fortunate to have within our group Dr. Bridge Manny, who's been one of the leading investigators on this device from a national perspective, and probably has as much experience as anybody internationally doing this implantation of this type of device. And so he's brought this technology with him to our hospital and to our vascular network, and it's really been a major change in how we can manage patients.
We're here with Dr. Eric Lieberman. Dr. Lieberman, where is your office located, and what is the phone number?
My office is located in Delray Beach. We're at Via Del Rey and Military Trail. Our office number is 561-637-0500.
We're going to take a quick break on Doctors Are People Too. On the other side, we're going to talk to Dr. Lieberman a little bit about preventative cardiology, peripheral arterial disease. I always ask cardiologists when I have them in, what is an echocardiography and how does it work? And same with nuclear cardiology, because I'm very confused as a member of the general population of the word nuclear with cardiology. So that's something that we can explain on the other side on Doctors Are People Too.
I make a dinner for me and my girlfriend. We ate, we enjoy, the dinner was very good. She was ready to go to sleep. I said, okay, I'm going to stay on the couch a little bit to watch TV. I started to feel something in my throat, like I was choking. And all of a sudden, I feel the pain, the sharp pain, like somebody put a knife in your back and open and do like this. That was when I called my girlfriend. I said, you have to take me to the hospital. I couldn't die. When they were doing the test, they saw something was weird. My valve was ripped. I said, God, please help me to get out of this. Dr. Valle was on call. He was who performed my surgery. I described like an angel. I described like he was there to do that for me. My girlfriend, my son, he told me when they saw him getting out from the operation room, he was sweating. He was tired to be there for 10 hours. For me, it's unbelievable. I can walk, I can exercise a little bit, and I can drink red one, that light red one. Of course, 1 glass or 2 glasses, no more. I see the life different. And I want to see my granddaughter to grow and my son to get old. So I wanna live. I think that God gave me one more chance in life, and I had to take advantage of this.
You are listening to Doctors Are People Too with David DiPino, who shows us the human side of medical doctors in the community. If you have a question for our guest, call into the show at 888-565-1470. Now, let's get back to the fun side of doctors and show that they are people too.
And welcome back to Doctors Are People Too, here on the iHeartRadio app and on WNN 1470 AM. If you have a question for Dr. Eric Lieberman, cardiologist at the South Florida Heart Institute in Delray Beach, number is 1-888-565-1470. Or if you have a quick question about the Innovations in Cardiac Care Symposium coming to Fort Lauderdale, right around the corner, right down the street, really, October 7th, 8th. And then more information is at thvnsymposium.com. Dr. Lieberman, thanks for coming back. And then also we talked a little bit about AFib is going to be a huge focus of the symposium, the Innovations in Cardiac Care Symposium. But this is another acronym that has come into the news lately, is the TAVR procedure to save people from deadly heart ailments. So I know that's going to also be a focus of the symposium. So if you could explain for the common listener, what TAVR is and how it can help out someone with a heart ailment.
So briefly, what TAVR is it's a way of replacing a valve in the heart without surgery or without traditional surgery. TAVR specifically relates to the aortic valve being the valve that separates the main pumping chamber, which is the left ventricle, from the main blood vessel, which is the aorta. And this valve can narrow over time. It gets calcified as it doesn't open well. And it is a life-threatening problem, as you point out. Patients with aortic stenosis, unfortunately, can die from that condition and die suddenly. Up until really about 5 years ago, treatment for this was surgical, as people think of the traditional zipper down the middle of the chest to open up the chest, take out the old valve and put in a new valve. Well, many of the patients who need this type of procedure are older, may have had a previous operation or at greater risk for surgery. And so a technique was developed to replace the valve without surgery, basically going through the leg and placing a new valve over the old valve and expanding it into place to replace the valve. It was originally done in patients who weren't felt to be candidates for surgery. It then developed into patients who are high risk for surgery, and initial studies showed that patients who are high risk for surgery actually did better with this procedure than surgery. There is now data out that shows that patients who are, quote, intermediate risk do better with this type of procedure than surgery. The risks are actually lower. What's fascinating from a cardiologist perspective is these are patients who are often quite ill, who now go into the hospital, and rather than being in the hospital for a week after surgery and then really not feeling back to themselves for 6 to 12 weeks, and unfortunately also facing complications of surgery, are often going home a day or two after their procedure is done. And frankly, I'm seeing them back in the office before they would have been discharged from the hospital, and they're back to their normal activities. I have a patient tomorrow who's 93 years of age who's going to be having this procedure done. And then we are actively involved at Delray Medical Center through our surgeon, Dr. Bethay, and our structural cardiologist, Dr. Manny, now involved with trials of low-risk patients. So patients who are at low risk for having their valve replaced surgically actually can either get it replaced surgically or with catheter-based therapy, and we'll see which is the superior technology moving forward within the next few years. So it's fascinating, it's exciting, it's opened a world of treatment that wasn't available to patients before, and done so in a much less invasive manner.
And Dr. Lieberman, I had to smirk when you said a 93-year-old who's going to be back to their quality of life in little to no time, because that is unbelievable to hear. We have a huge baby boomer population right now, and it seems like a lot of people, in the future are going to live to 100 and beyond and have surgery late in life. And as a cardiologist and staying up on the latest things by having symposiums and clinical research going on, it seems like the quality of life just continues to improve at such an exponential rate so fastly. That's great to hear. I gotta thank you and all the cardiologists around. That was really great to hear.
It's fascinating. Actually, the only conflict I have with October 8th, which is our CME program, is the same day I was invited to one of my patients' 100th birthday party, which unfortunately I'm going to miss to be at our symposium. But, you point out, we're seeing patients live not only longer, but longer with improved quality of life. And that's really what this comes down to, is what can we do to improve the quality of life of the patients we take care of, and do so in a way which is less invasive and is able to maintain not only longevity, but quality longevity.
And as a cardiologist staying up on the latest and greatest, you're able to identify maybe and do the tests necessary for a patient that may need, treatments for AFib, or if they're a candidate for TAVR, or even LVAD, which I'll ask you to explain briefly, but you're able to identify that as a cardiologist and then get them to your team of surgeons and structural heart cardiologists and et cetera. So that's great to know. Is that kind of what you can identify and help out in that way?
Yeah, I mean, our role is to identify patients, to treat them as best we can medically, to identify when a patient would benefit from something that's more than medical treatment, whether it be surgical or a catheter-based approach, and to work with our surgical colleagues, our interventional colleagues, our electrophysiologists, to give them the best advice and the best treatment options so that they can be taken care of in an effective manner and maintain that quality of life. And you touched upon before the break, technologies do that. Echocardiography is one of the main methodologies in which we do this. An echocardiogram is basically an ultrasound of the heart. But using ultrasound, we can identify function of the heart muscle, function of the structures of the heart muscle, the valves of the heart. We can look at whether a valve is narrowed or leaking, whether a heart muscle is functioning normally or abnormally, so that we can identify the best treatment for a patient.
And we're here with Dr. Eric Lieberman of the South Florida Heart Institute. That's 5035 Via Del Rey, right there in Delray Beach. I believe it's the corner of Lake Ida and Military?
Slightly north of Lake Ida, right on Military and Via Del Rey, which is just slightly north of Lake Ida. You're correct.
So north area, Delray Beach, right next to Boynton there on the border. Right there and the number there is 561-637-0500. Dr. Lieberman, talk to me a little bit about your team there. I know you have a great group of cardiologists. It's not just 1, 2, 3. I think you just added one this week.
We did. So we're now 6 cardiologists and a nurse practitioner. So there's 7 of us working together, and I think that actually underestimates really what goes on in that office. We have a terrific team of nurses, of medical assistants, and our office staff that make the patient experience, I hope, as positive as our patients see it to be. And my colleagues include Dr. Mark Fisher, Dr. Mark Gardner, Dr. Arthur Weiner, Dr. Jonathan Baffai, and Dr. Jonathan Kahan, as well as Becky Craig, who is our nurse practitioner. And I'm fortunate to be surrounded by people who I enjoy working with, who I respect, who I'm happy to say take care of my family members. And we work very closely as a team to coordinate care and do what needs to be done, identifying what's best for the patient and taking care of them.
I gotta tell the listeners, this is one of the most appealing doctor's offices in South Florida. It's in an area where there's not a lot of traffic for some reason, which is hard to find on the east side of the Turnpike in South Florida. And it's got this river stone on the outside. It's very appealing landscaping. Then you drive in, and if you're lucky enough, you can even get a covered, shaded parking under the columns in the front. Easy to get in and out of. It's really a gem of an office, I have to tell you. I mean, do you hear that a lot from your patients?
Yeah,
huge parking lot. I mean, every location parking.
Yes, I'm glad you mentioned. We actually, when we developed this office space, parking was a big issue because we'd heard complaints about that in the past. So parking is not problematic at our office, but I do think that we strive to make the patient experience as comfortable as it can be. And we understand, while we go to the office every day and it's where we live, for our patients, it's a traumatic, difficult experience going to a physician's office at times. We want it to be warm, welcoming, and comfortable. We also firmly believe in a patient's time is as valuable as our time. So we do try and move things along. I often receive comments from my patients that they're shocked at how they're not kept waiting. I think we try and schedule things appropriately and keep people moving through the office at an appropriate pace. That's not to say emergencies don't come up and occasionally we fall behind, but in general, things run very smoothly. And again, we have a staff that really understands the patient's needs, is sensitive to it, and an incredible support staff to make the process as smooth as possible.
Dr. Lieberman, thanks again. And listeners, don't forget Innovations in Cardiac Care Symposium, October 7th, 8th in Fort Lauderdale. Visit thvnsymposium.com to learn more. Dr. Lieberman, thanks so much for making time on Doctors Are People Too.
Thank you for having me. I appreciate it.
Thank you for listening and watching Doctors Are People Too with David DiPino. Join us next week for more in-depth views on what doctors are all about and how they spend their free time. All shows can be seen on amp2.tv. And if you have questions you want answered on the air, call 866-224-5422 and leave a message that can be read on the air. The opinions expressed on the preceding sponsored program were strictly those of its hosts, guests, and callers, and not necessarily those of this station, its staff, management, or